Welcome to our workshop today, Health Equity. Who owns the agenda? I am Dr. Vineeta Gupta, maternal and child health physician, international human rights lawyer, and director of the Action Secretariat. Action is a global health advocacy partnership consisting of 15 locally based civil society organizations across 5 continents. And to learn more about us, please go to action.org to learn more. And there's on the right side, you have the chat, and you can see the URL posted there. As we go along this workshop, we want to hear from you on this conversation. Please share your thoughts, any thoughts, comments in the chat box on the right side of your screen at any time during the presentation. We will have plenty of opportunities to interact and do some really deep thinking on this issue, a very crucial issue. You can also engage with us online and each other and larger community by using hashtag #YesHealthEquity. We will be live tweeting during this event, so let's make it dynamic. This event is being recorded, as you saw it on your screen, and will be shared afterwards. Like I said, we hope to make this workshop interactive, candid, challenging, and inspiring for all of us. I know you are a great set of advocates to be here today, and when we leave this room, I am 100% sure that we all will feel even more inspired. So let's see, what are the objectives of our session today? It is to strengthen our thinking on the place of health equity in achieving global health goals. And who dominates the agenda? What can we do to build a South-North allyship to co-create and push the agenda forward? And I want to underscore co-create. Often in our field, what happens is that the agenda is formed somewhere in the donor countries and brought to the implementing or the South for implementation. And what we will be talking about in this session is how to advocate for co-creating the agenda and then pushing it forward as equal partners. And we will be having a guest on our session today. Hopefully he can join us. Oh, he is here, Dr. Yogesh Jain. Dr. Jain is a pediatrician and a founding member of Jan Swasthya Sahyog, People's Health Support Group in India. It's a fantastic organization, very rooted in the local needs, and that's what defines them and that what drives them. And Dr. Yogesh would share in a minute. So Dr. Jain's work as a physician has been at the intersection of health equity and primary health care. Founding and running a community health program in central India since 1995. And Dr. Yogesh and I were talking before, we come from the same batch of medical school, different schools, but same batch. So it was great getting to know Dr. Yogesh Jain more. Please see the link to his bio in the chat for more detail. And his hashtag, his handle for Twitter is also there. Please tag him also when we go through this conversation. Now, I am going to start the first session. What is health equity? One thing this group seems to agree that it is essential for achieving any health goal. So let's look at the poll that I posted in the session. So we have 34 people polled for this poll, and 33 people agreed that health equity is crucial for achieving any health goal, global health goal. So I have 30 years of experience working on this as an advocate, as a physician, as a human rights lawyer, bringing case laws. What I have learned is that health equity is the most difficult thing to achieve. I see it as when I was a child, we would go to circus and there would be a ring of fire, and the line will go through it. It was very exciting for kids. It appeared so dangerous and so hard to do. I visualize health equity as that ring of fire. You have to go through to get to the other side. It is the most difficult, but nevertheless, most essential thing to achieve any global health goal. And we'll talk more about it. For this session, we'll be using a Jamboard. To add your thoughts, please click on the sticky note you can see on your screen. So we will click there. You can write in that note, and then you can click save. So it will be on the Jamboard. You can also post your, whatever your thought or message is when we go through this exercise. You can post that in the chat, and our team will be putting that in on the Jamboard for you. So let me invite you to please share your thoughts in one word or a very short phrase on what comes to your mind when you think of health equity. What does it mean to you? Anything that comes to your mind, just for the easy read, try to synthesize their thoughts in either one word or 2 words or a very short phrase. So I am going to ask Sabina, our tech and all the things great happening in the background, to please get started with the Jamboard. Once again, please use one word or a very short phrase to talk about what you think when you think of health equity. What does it mean to you? Let's go. Let's have 5 to 7 minutes to do this. And feel free to post in the chat. We'll post it in the Jamboard. Thank you. Fantastic things coming: human rights, compassion, empathy, equal access, health coverage, listening, access, human rights. Everyone has access to all widespread health solutions. Quality. All inclusive. Primary health care. Human rights and justice is very, very popular with our responses. Fantastic. Affordable for all. Everywhere. Trust. Meaningful. Effective. Preventive medicine. Relevance. Personalized. Awesome. Thank you, everybody. Fantastic responses. So let's pull up what WHO has to say about this definition. And you've already covered all the words, already covered what it is in there. But let's pull up the World Bank's, WHO's definition on health equity. So according to WHO, and you can see more, we will be sharing some resources. You can read more on nuances of health equity in the resources that we will provide in the side. WHO says equity is the absence of unfair, avoidable, or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically, or by other means of inequality. Example, sex, gender, ethnicity, disability, or sexual orientation. Health is a fundamental human right. We saw that your responses, we saw that we all believe that it's not a privilege, but a right that should be available to everybody, no matter where you are born, no matter how you look, no matter what you earn. And then health equity is achieved when everyone can attain their full potential for health and well-being. Now, how many people, please raise your hand, how many people have read about health equity during COVID-19? Please use the function, raise your hand, clap, whichever, smiley face. So what happened during COVID-19 is that everybody was talking about health equity, what the need of health equity is. Health inequalities or inequities existed before too. It's just that we as a privileged country, as a high income country, got more in tune to it because it was affecting us as well. It has been come and gone with different buzzwords, but it existed, it exists, and it's going to exist unless and until each generation that's working, advocating for better situation for everybody to access health beyond curative health, we all work hard and visualize it as a generational work. It's not going to end with our generation, right? Sorry to break that news, but definitely we can make a difference. Definitely we can make good run and hand over the baton to the next generation to make it even better. So what we say when we say, why does health equity matter and why should we care as global community? Now, I'm going to invite Dr. Jan to please help us understand that more and share your thoughts on why health equity matters and why we all should care about it as a global community. Dr. Jan, over to you.
Thanks, Vineeta. I have been observing the question, the responses that came to your question in the chat box, and to me also, like others, means health equity to me also means. I would start with some negative definition. It's not a scheme, it's not a strategy, or it's not an arrangement, or even a largesse of a welfare state, if I may say, but largely a justice issue, or what I would call a fundamental rights issue, in which each one of us has a right to remain healthy or become healthy if one falls sick. And what this would imply is what I would say is where the devil lies in the details, is that the determinants for remaining healthy, whether they are social, also called the social determinants of health, or health systems, or economic issues, or I would even say political issues, are provided equally. And I would, if I unpack this further, I could go on to say that it would mean that components of health systems, which also includes the production of knowledge that drives what should be the infrastructure, the equipment, the drugs, the human resources, and the standard operating procedures that are done in health systems, they are underpinned by equity. This would be ensured that we have to ensure that to happen if we really care about the word health equity, which I think is a much abused word already. Or else, if we don't underpin it by equity, all these components, including production of knowledge, then we create inequitous health systems, one for the poor and one for the non-poor. And thus, for the ones which are for the poor become poor health systems. In fact, that's been the experience. Poor people get poor health systems. If we have two sides, if you don't have a universal healthcare program, and for the non-poor, they go another way. And then, as we know, that people who decide what health system should be developed, actually, those are the people with some power. They don't suffer the consequences of their own decisions. And those who suffer those health systems, which have been decided by people who are in power, don't have a voice to influence how health system for them should be made. And I could go on with examples if you would like to have hear me, or I could wait for a second level of questions about how health equity should be. How do I observe health equity not being done because of various reasons?
I think, Dr. Jan, please go ahead, share with all of us any example that comes to your mind.
So I would say my largest grouse, if I may say that, is in the form of knowledge creation, which some people in multilateral organizations or in academic institutions have created, for which determine what type of health systems are being bandied around by people, by funding organizations, or by aid organizations that are linked to national governments in the Western Hemisphere for the people of the South, which include, if I may start with my one of my biggest problems is the idea that you can provide healthcare for everyone through privatized health systems. Would you not agree that in nowhere in this unequal world of ours, and we are a very unequal world, has a privatized health system be able to deliver healthcare for all? I don't think of any country in the world that with a predominantly privatized health system has been able to provide healthcare for all. And the fact that 75% of outpatients healthcare in my own country in India is provided by the private sector is often taken as their willingness for privatized health systems. What I think is, usually the desperation for healthcare in the absence of functioning public health systems, that they are forced to go to private system, is used as an excuse to sort of speak up for private systems and for privatization. And that's the pundits all over the world, I must say, and in academic institutions or in multilateral organizations, they start, which was pegged to start with the World Bank's structural adjustment programs in 1993. That infamous report that came out in 1993, which led to rolling back of public investments. That was the recommendation that was made, and user fees, which was often later, obviously, retracted by the World Bank. Is these rolling back of privatized or public health system was being touted as a way to go forward for healthcare for all. And if suppose, for example, if in a country like United Kingdom, no one in position of power would be able to get elected if they spoke for disbanding national health scheme, even if they speak there are problems with the NHS in UK. But in India, imagine all funding organizations that come to India and their academic houses support privatization of healthcare. In spite of the fact that we are seeing during COVID times in these last 2 years that not only inequity has increased all over the world, with the rich becoming richer and a lot of people becoming extremely poor, most people becoming much poorer, and only those countries we know, or regions within countries which had some sort of a modicum of robust public health systems, were able to survive. And the government of India, as well as the champions from the Western world, keep on promoting the role of private health systems, could realize that the private health system failed in India to provide healthcare when it really mattered. And even if they were being, so-called people were falling over each other to support the private health system, these guys stopped. They closed shop for most of the 2 years of the pandemic, and only whatever care was provided was largely by the public health systems. But still, we keep on talking about privatization of healthcare, and countries like India support privatization not only in terms of the health systems, but also the pharma industry, or even talking about the private health education. Medical education is also tried to be privatized. So I think this is one of the major challenges, that privatization is a major challenge for having equitous healthcare for everyone, for the last person, as the Mahatma Gandhi's talisman, that look at the face of the poorest person in the world, and if whatever you're doing is supporting that person's care, then that all your doubt should melt. And I would say most things that we have seen, privatization of healthcare cannot deliver healthcare in an unequal world, is an axiom that I would still sort of suggest for all of us on this call. And so my one, besides the privatization of health, which has been one of the sort of knowledge creation device that has been used by people in power in the Western world to mess up our healthcare, I would take about two other examples. Where people who decide for us, look at the discourse for universal health coverage, as WHO calls. They don't even want to call it universal health care, because that would mean ensuring social determinants of health also for people to be able to get universal health care. They say there are three things required to get universal health care. One is political will, which would be usually the national government. And then what are the ways to do the nuts and bolts of providing universal health coverage, which would mean usually public health system, which are strengthened, as well as the ensuring pooled procurement for drugs and diagnostics, and having a system of regulating the private sector. But the third thing is the people's demand for it, whether people are asking for it, the public at large, and can they ask for it also, if I may say. We don't have a culture to, at least I can speak for my own country, we don't listen to people at large. We don't have a participatory democracy in our country insofar as health is concerned. But I must say this is also a peculiar problem in healthcare, that people who, when people are sick, they cannot ask for, they can't demand for healthcare, or take the public health system to task for not providing healthcare, because at that time they are vulnerable. They want healthcare at any cost at that time when they're sick. And when they're not sick, people don't feel the need for healthcare. And that's a peculiar problem for health rights movement overall. But having said that, I think there is no way but to ensure that people actually who need healthcare, their voices are heard. And there's no way forward to get universal healthcare until people start asking for it. And I would say then in this case, the problem is also in the way the entire discourse of UHC, universal healthcare, has been taken on by people in power in the Western world and our own national governments. And I would even use another example, if I may, which is a specific example of a disease. Let's look at tuberculosis. The World Health Organization developed, after the worrisome resurgence of tuberculosis in the mid-90s, a strategy called the Directly Observed Treatment Short Course, the DOT strategy, which was proposed to be 4 drugs to be given over a 6-month period, but to be given thrice a week. So an intermittent dosing system was advised, where everyone would have to go to a health worker after the diagnosis is made, that they would take treatment, they would have to see that the tablets actually go down the gullet of people. So this was a recommendation made, and more than 90 countries in the world took on the WHO's recommendation. In fact, I think close to 150 countries took it on. In 2005, when India also had implemented it for a few years, when in my own state of province of Chhattisgarh in central India, we also implemented the DOT strategy. We realized that a lot of people who were started on treatment, and particularly children, were coming back with relapses of the disease within a few months of stopping the treatment after 6 months of being given thrice a week treatment. And when we looked at it, we realized that those people who had isoniazid, one of the main drugs in tuberculosis, resistance to that, or those who were severely undernourished, which is a common problem in the type of tuberculosis that we see in India and other parts of the poor world, were coming back down with relapses. And when we looked at the guidelines of 1990s, where WHO had promoted this thing, there were no references to the guidelines. And I think it was something like what I would call it as a GOBSAT. Good old boys sat around a table to make a guidelines of an intermittent treatment without looking at the implications, where tuberculosis among the poorest, among the most undernourished, could actually be, whether they would relapse or not. So we raised this issue in 2005 with the WHO that you should withdraw this recommendation of intermittent treatment for tuberculosis among those who are undernourished and those who may have drug resistance to INH, at least a single drug resistance. They were only bothered about multi-drug resistant at that time. But the knowledge creators, the WHO, took at least 12 years. That in 2012 they came with the guidelines that, oh, we should give daily treatment now. And by that time, a lot of people had relapsed. And I must say, in my own country in India, the National Tuberculosis Programs Department did not even change till 2017, when we, as a group working in central India, among the in forested areas, went to the Supreme Court of India to ask them to withdraw this recommendation and to issue the guidance to the state to give daily treatment for tuberculosis. And that it required a judicial intervention to make a medical technical intervention change. So in which, I think the way my point that I'm trying to make largest is that those who decide, who create knowledge, and how the knowledge is created for how health equity would be made available for people, have to take the blame for ensuring that for not ensuring, for seeing that health equity has not actually does not actually work. I'm not trying to sort of put it either on the Western governments only. I think our own national governments and the pundits that they consult often, without consulting the public, the people at large, have to partially take the blame have to share the blame among each other, among themselves, to say that that health equity remains a mirage, if I may say.
Thank you. Thank you, Dr. Jan. So I want to reflect on a couple of things you mentioned and then come back to you again with a question of like connecting the primary healthcare and healthcare equity, the importance of it. I'll come back to you after I kind of want to reflect on some things you said. One thing you said about the health equity word being abused. And next session, we will go deeper into it, that who owns the agenda? Actually, this is the whole thing. Like, we talk about health equity, but where is it happening? Who is controlling the agenda? Who is getting the money of it? So we'll get to the next session on that. But definitely when in vaccine inequities that we all know that is happening, the vaccine for COVID-19 is not equitably distributed around the globe or have access to. We all know that when corporate pharma starts talking about equity and with their megaphone controls the whole environment, then indeed you can see how it is abused. It's hijacked by the people who are themselves part of the problem. So we'll come to that. So that was great sharing, Dr. Jan. And then the other point I want to reflect on is people who make the decision, Dr. Jan shared, do not often get the consequences of their decisions, right? So that's where this group comes in very good position. The results grassroots groups have such power to impact what's happening in the US. As US has the it's just not even comparable. We'll talk about it a little bit in the next session again. It's not comparable. For this group has so much power to shift the paradigm, to contribute in that the people who make the decision, even if they're not getting the consequences, so they can be more, what their electorate wants, electorate wants, and we are those people. We can tell them, we want it. Your vote is going to be the consequence if you are not putting the health equity on the top agenda in a manner that would work. So that's another point. Third, I want to make a point what Dr. Yogesh mentioned, Dr. Jain mentioned, privatization of health. I remember, now I'm going to age myself there. 1986, I was heading postpartum unit in a secondary level hospital in India, in Punjab. And I wrote this whole report, which I traveled with in lots of European and US universities and city governments to share that how user fee is affecting the access in an adverse manner, right? So the World Bank gave the money to India to kind of Maharashtra and Punjab were kind of two initial states that they pushed the privatization. It was already problematic. People were not getting access to quality care or care at all. And then on top of it, the solution from World Bank came with more problems without removing the initial problems. So what was the consequence? It became worse. And another thing that having lived there, provided health services in India and coming to live here 20 years ago and losing my health care, losing my privilege of having the best quality care in India, I've suffered on the both sides. And I consider myself fairly educated. I cannot figure out how the system works. I get all the times when I am in the health system, I'm like, oh my gosh, I can't go through this without having to just like leave to fate, right? How are we going to put the system that's a failure in the most privileged, most powerful country in the world in LMIC, low and middle income countries, without seeing what would work there? Because we don't put them on the table at the right time. We put LMIC on the table at the time when decisions have been made, again, referring back to what Dr. Jan said about the power. Where is the big power? They don't engage us at that time. That's why this group, and I see 96 people, robust, committed, long-term advocates, have a very big power to shift the needle on that. I know you are shifting, but this is, I hope this session helps you even one, energize, inspire, and know that your work matters, know that your advocacy matters, and that you are going to help next generation. We all are going to help next generation do better. So the next one I would say is, Dr. Jan mentioned participatory democracy. So Dr. Jan, sorry to break the news, we also suffer from that to a large extent. So look at the reproductive health, right? Over 60% of the electorate in US supports women's right to choose. And still regressive policies are going on everywhere, every state, right? So just want to say that we have a power. We need to use it more effectively, consistently, and not get discouraged if we don't see results. We are needed. So that's what I would say. And then closing this one and going back to Dr. Jan. Dr. Jan, could you please share the linkages between health equity and primary health care?
Sure. So I would say, if I may, actually, for getting health equity, there is no way but to have the people actually raise a voice. I would say the example of United States is, is a poor example of, of whatever equitous healthcare that we know. I mean, even in they're better than they're better. You are better off than in India, but not better, not far so, not so much better off than many of your other poorer cousin countries in the Western Hemisphere. So, but I would use this word, without asking for milk, even a mother does not offer a child her breast. So we have to get people together to be asking for healthcare. We cannot allow these, men, sort of, largely there are men sitting in these, fora, as I use the pejorative word of good old boy sitting around a table, without deciding for the healthcare of everyone else. So I would say that we have to find ways of getting people together to ask and demand for healthcare and to struggle. This cannot be a largesse of a state to provide equitous healthcare. There has to be a demand and a struggle that is associated with it. And I think this has been one of my largest works that we have been trying to do, to organize people to ask for their own health rights and to sort of struggle for it, whether they are in form of making petitions to the providers of healthcare, or to complain about the providers to through a judicial route, or even by taking to the street, if I may say. And I'm sure sooner or later people in the United States are going to go down. Women at least are going to struggle for the right to choose and get back their long fought successes that they are likely to lose if they don't, if this thing passes in US, that you lose the right to get to abort your unwanted pregnancy if you need to do. So I would say, but so the struggle which is through people's peer support groups for patients of various illnesses are the ways that we have tried to sort of recommend whether someone with sickle cell disease is able to get drugs free from the state government, from the state health systems, whether people with diabetes are able to get their disease recognized. For example, India, we don't have only type 1 and type 2 diabetes. A lot of adults young adults have what we call as lean diabetes, which the International Diabetes Association or the World Diabetes Forums don't even count it as a phenotype of diabetes that is seen among the poor. How will we ensure that that comes in through? It is not that the pundits of sitting in some of the top diabetes departments of the world are going to make this change. People will have to sort of speak up for their own problem, and with our own academia, and largely I must say academia has failed the people, at least in terms of health equity. If equity has to come in, it will come through the struggles and the sweat and the toil of the people who are suffering. But I'm having understood this point that health equity is not one of the basic equity issues that people ask for. Poor people have many issues that they need for to be sorted out, and health often gets falls behind in the race for various other demands that people may have. But there is no other way but to sort of struggle for it. So peer support groups of people with common illness, or I would say the forums that are around any form of formations, whether it is microfinance groups, or I would say feminist groups. I would say they are one of the biggest champions of trying to get health equity. It's a feminist perspective. It's not just for women, but feminist perspective on health is such a critical thing. And I would count myself as a feminist to get, trying to get healthcare for the people, equitous healthcare, which would also be and allow other axes of marginalization. I would say the groups of indigenous people or Dalit movements would be those who would be asking. I'm talking about the most other axes of marginalization, or people with different sexual identity. Those would be the ones who would ask. So I would say among some of the successful peoples-based programs have been those for HIV, where people could get drugs for everyone in Africa. The TAG movement of the Treatment Action Campaign of South Africa was one of the most successful ways to get one of the measures of health equity in place. And why not for other illnesses, and why not for all types of things? But I must say the role that pressures can play on knowledge providers or knowledge creators, whether it is the World Bank or the academic institutions, will have to continue. And I think networks of people who work on health equity, including many are over on this call, would be important to sort of shake the people who are sort of deciding into considering the voices and the representation that are made by people on the ground, to listen to them and not ignore their voices, and to get them a place on the table would be one of the next ways to do. And I would urge the multilateral organizations or funding partners to insist, even with national governments that they are supporting, or state or provincial governments that they are supporting, that they should insist on having people's representations on whatever fora there are to decide on the practical details about health systems that are going to be used on people. Over. Yeah.
Thank you, and just fantastic sharing. Thank you, Dr. Jan. And I want a couple of things I want to emphasize again. I can't emphasize all the things because everything was so crucial and important. But let's just say a couple of things. One is, like Dr. Jan mentioned, we have our own challenges. So when we think of health equity, it is not somewhere there. It's within countries, it's between countries, right? It is not isolated from socioeconomic inequalities and inequities, right? So I know from my own experience that when I was in India, I had privileged. If I sneezed, I could have 10 doctors, best doctors of the city at my bedside. And when I ended up moving here, and due to whatever reasons happened to lose my health insurance, I dislocated my big toe, and I did not have money to go to a doctor and get it. I had to sit home and do it. So I was privileged in India, and you can say, oh, it's an LMIC. So it's not homogeneous. It depends on within countries we have disparities, and between countries we have disparities, right? So that, and also I think that if you see in US, the Black maternal mortality is trending in wrong direction, right? And we have our leaders, elected leaders, who say that if my state, say for example in Louisiana, said, the senator said, my state's maternal mortality is same as national if you take out the Black women out, right? So it is so ingrained into the power and this thing that we don't think it is, and there's no outrage to the extent that I would expect, right? Saying it out loud, not understanding, not even bother to say that. So we have our own challenges within our country. And there is another thing I would want to point out here is learning. We always look towards LMIC, hey, let me teach you. And I have gone to I've worked in 30 countries doing the programs on RMNCH, reproductive, maternal, and child health. It's always, let me tell you what to do. That's the approach of US investment or the donor country investment in LMIC, right? It's time that we learn, co-learn, treat the partners not depending on what country GDP is, but what they have and what we have and where we can co-learn and improve our systems. So that's another thing. And I would go to the last point on what Dr. Jan said about the funding partners. Now, funding partners, when it comes to national governments listening to their people, funding partners, whether they're multilaterals, whether they're individual, rich, philanthropic entities, they raise their hands. We don't interfere with the domestic governments. Oh, it's their localization. They use all those fancy words without really using them. Whether it was like ground up approach, then it was country led. Now it is localization. They use all those words to stay out of the uncomfortable zone, but then they define the micro agenda, how we should fix the problems in other countries. That prescriptive is there. But when it becomes the larger influence on the governments, then it's like, oh, we don't interfere. So that's another thing to say, that we need to have equitable partnerships. We have to have those partnerships to, so now moving on to our next session. This is really great. Thank you, Dr. Jan, for sharing all those direct experiences. Now let's go to who owns the agenda, right? We dabbled here and there on that. We mentioned a little bit here and there, who owns the agenda? What do I mean by that when I bring that question up? It is, who do we hear, right? We talked about health equities within the countries and between the countries, globally, and our role. But when do we hear about health equity? Who do we hear? Who's talking about it, right? So I'm going to bring a very superficial example, because we are having this debate and conversation, not a scientific, it's not scientifically done what I'm going to share with you, but let's just pull up a screen on, we did 2 months of Twitter, right? First of all, Twitter is very Western, donor country sort of thing. So let's bring up some slides on when we looked at health equity. Do you see in last 2 months, who used the word health equity on Twitter? Do you see how many percentage? 95% was in English, right? Less than 5% was in rest of the languages. So that's one determinant, right? English speaking are dominating. Obviously, Twitter is mostly used by English speaking, but there are other languages as well. So let's go to the next slide. Now, do you see, where is health equity? 80%. 80.99 means 81% of the chatter is happening in US, and then 7.64% in Canada, 2.07% in UK, and rest of the world 9.3, right? So this is who's talking. And you know what they're talking about? If you see what you have read in US, at least what I can see and I have read, it is talking about, hey, over there, health inequities are there. Not as much as we are facing. Everybody in the global health, in health is facing inequities. We talked about Black maternal mortality. We see the difference in Washington, D.C. Northwest and Northeast. We see that, or Southeast. We see that difference. You all in your community see that difference, right? So the point is that people, and then if you see the entities, if you go deeper, the entities who are talking is the people who are actually some of part of the problem, whether it's me, whether it's some of the entities and the what Dr. Jain used as the pundits, right? Sitting and talking, we are taking lots of space for that. We are not bringing enough voices from the countries and co-sharing rather than you have the problem, come and talk to us, tell us your problem. Now, so let us go to another exercise that we'll be doing for this. Share your thoughts and also please use the country to your message, right? So that we can know where you are located and what you're thinking. On who do you recall reading on health equity and where are they from? Which magazine or website comes to your mind? Who you know as social media influencer on health equity? Whose tweet you saw, where they are located, who comes up when you search health equity? Who do you think gets the most resources to advocate for health equity? So I posed a lot of questions. You don't have to answer all of them. The point is for us to share in the chat on who's talking about health equity, right? Who are we absorbing from? Are they good share of voices from countries, or is it more northern countries' voices? So let's just go with the Twitter. Please don't forget to put the location where you are from. Just country or city, whichever way you're comfortable. We'll give a few minutes for that. Very good, very good sharing. Thank you. Dr. Madhu Pai, Peter Hotez, Heather Hitt, Paul Farmer, Blackstock, Single Payer Action Network, Ohio. Physicians for National Health, Partners in Health, Teresa Chapo,
Dr. Vineeta Gupta.
thank you. I'm also here. Matt McGorry, JL Calderon. Results.
Médecins Sans Frontières.
Correct. Health promotion, youth and women advocates. Okay, awesome. So you see what we see, right? We are all, one thing is like acknowledging that we are all based in the US, right? Larger part of our audience today is in the US. Let's do that. Let's do a little exercise here quickly. If we can see the show of hands who are based in US, just the people who are based in US, if they can raise their hand today. And we have 103 participants today. Sabina or Maddie, would you please help me track the raise of hands? So this is great. It's Am I reading it right? It's 29 people who raised the hands?
Well, I see 42 hands raised and then a thumbs up and a clap, and there are probably more of those because those disappear eventually. 45 hands raised.
45 out of 103. So that's great. That's kind of an eye opener. We have very wide audience here. Fantastic. And at the same time, we've heard mostly US-based activists and advocates.
Well, I would say immediately that health equity. This is a word which is not easy for anyone to understand in a non-English world. Equity, yes, first, but health equity, actually comes from equity underpinning in other determinants of health. So whether it's and we only see the consequences of inequity, as I would say, as I would see in my own in our work areas. For example, the entire promotion of tech fixing poverty. This that is promoted by the knowledge creators of the world, who say that a vaccine or for say a waterborne disease is going to fix illnesses. One specific vaccine for an illness, a waterborne illness, rather than to ensure safe drinking water for a child. So I would say it's easier for a child in a African or a Asian country for a disease like rotavirus, but not to get safe drinking water is a reality that most people would face. So I would say the question I would sort of expand the question to say consequences of inequity, or equity in a more generic sense should be the question asked about when one talks about health equity, and not this phrase called health equity. This would actually eliminate most of the people who suffer the consequences of health inequity, and then that is not very helpful. So I would again get back to the idea that people who suffer the consequences of inequitous health systems or inequitous public systems need to talk about their problems and get together to demand what they really deserve. If we are actually, we really believe in in that all people are equal, and which I think is something that doesn't really happen. I don't think most of these things are optics. We're talking about very superficial things when we talk about health equity as a concept. The devil is in the details, and I think there are huge issues that we don't see where health equity is being operationalized. I don't think it's being operationalized anywhere, certainly not in my own country. Say, if I would may, sorry, before anyone asks, my own country puts in 1.1% of its GDP on health. You can't even think about health care for everyone with that level of of funding commitment. And even among that, the money goes to private providers, because we believe in an insurance system of healthcare rather than universal healthcare system, which is tax-based funding, like what would happen in UK or in Canada or in Australia or in Scandinavian countries. Yeah, I think we need
South-North allyship to co-create. Let's wait a minute for the PowerPoint. Co-create and push the agenda forward. So what we are going to do with this, we will discuss this in small groups in breakout rooms. We will randomly place you in a group. On purpose, we have made really small groups. One, so that you have good, robust discussion. Second, it's a good to get to know better and a deeper discussion. What you're going to see is on the top left of your screen, you'll see your room number. So you're going to click on the Jamboard link that you will see in the chat, and then go to the same number slide in the Jamboard. We will show you the Jamboard in a second. So you're going to capture your thoughts. Sabina, can you please share the screen? So do you see, this is the Jamboard, and you see there's a screen number up there, right? So you will go to your group screen and you will click there. Yes. And then what you're going to do is you can write on the note and then save and move on. So what is most important for this session is that you have robust discussion. That is the most important thing. You're 4 people in this one room. And just at the, we will have good time here. So write 3 or 4 points that you think that global community can do to build allyship, to co-create and push the agenda forward. Once again, we'll go to the small groups, breakout rooms. We will click on the Jamboard number coinciding with our room number. We will have a robust discussion and we will capture our thoughts, 3 to 4 points, what you think we can do to build allyship, co-create and push the agenda of health equity forward. Don't worry about making it pretty, making it look good. Point is to have good discussion and put your thoughts out. And then we will come back to the main room and then we will have the debrief on it. So thank you very much. First of all, is everybody ready? Can we have a show of hands to see that we are ready? Any question quickly, we can post on in the chat if there's something not clear. There's a link in the chat too. You will see on the left side, on the top of your screen, you will see the room number that you are in. And then you can go to the Jamboard, and if you see the above 1 to 20, you can go and click there. You will be joined automatically, so you don't have to do anything to join the room. We will put you in the rooms and bring you back in the room. Do not worry about that. Just the Jamboard part is where you will need to click on your board. And even if you don't, that's fine. All we need is to capture 3 to 4 things. Lynn, I think that we will stop by your room. Just put in the chat and we will come to your room and then help people. Anybody who's having problem in their room, just put in the chat and one of our team members, we have Madison, we have Sochi, we have Sabina and we will bump into your room and then help you navigate that. Awesome. We are not, Heidi, we are not yet in the rooms. We will go in a second. Okay, are we ready, Sabina?
I'm ready.
Yes, Dr. Jan, let's go. Hold on. Before we go into the rooms, can we show using the sign clap or whatever, thumbs up, whatever, before Dr. Jan goes and thank him for being on our session here. Thank you, thank you, thank you, Dr. Jan, for great. I'm going to clap here. You can hear my clap. It was incredible and incredible. Thank you.
My pleasure. Thanks.
Awesome, awesome, awesome. Thank you. Okay, let's everybody go to the rooms.
All right.
Are we all back? Sabina, I'll wait for your heads up, green light to start again.
I believe everybody's back in.
Awesome. Awesome. Thank you, everybody. I hope you all had good discussion. And I saw some Jamboard, really good sharing in the Jamboard. Let's go as a next session as a wrap up. First of all, thank you for working through the tech issues. Let's go to the Jamboard. Sabina, could you please share the Jamboard with us? Sabina, are you there with us? Awesome. Awesome. So really good discussion that happened. Okay, we are at 10 slide. Let's go to number 1, please. And we'll take a couple of minutes. We are not going to go through all of them, but we'll just take a couple of minutes to see what we have. And then we are going to do is put them all together and share with the group, either through our app or we'll email everybody. So we had really good discussion, it seems like all of you. And the theme that is emerging is educating ourselves, educating the funders, talking about the issues to the leaders, amplifying the voices, health literacy, and problem is like rooted in health systems, next steps for bringing the mindset for US entities. So some great thinking. And as I said, we might not be able to go through all the great ideas, but let's have a visual look at all the boards, and we will put an analysis and synthesis of all this great thinking to share with you. Let's scroll through quickly through more evidence. Decision makers show the impact, fantastic. Outreach, accountability, that's great. And not pitting global versus domestic issue. Yes, that's a great point. Rather learning from each and connecting them, how we are connected. So those are great. Next, please. Women and children are often most harmed and marginalized. Yes, excellent point. Moving on, we'll just go through really for people to have a look at it. Convene community partners, improved expanded Medicare. Awesome. Next, please. Yes, people have their needs that seem supersede. People in poverty are focused on surviving, feeding. So the advocates for us to advocate for poverty-free world, and that's what results stands for, right? All of you are volunteer, most of you are volunteer with results and connected in some way or the other. That's what will actually is the core problem. Moving on to next, please. Awesome. Advantage, yes, G7, moving on. Thank you. Thank you. Adherence system to ensure, lift up the stories. Young people at the center, yes. Awesome. Awesome. Put control in hands of people, absolutely. Awesome. This is great. Very good. As you can see from all the slides that we had a robust discussion on the issues there. So thank you. Thank you. So let's put up a slide, Sabina. Let's bring a slide up to all this discussion we had put in the bigger buckets. Let's bring up our slide on the key takeaways. So, see the power, there's so many power denominators, right? So the key ones in health equity is where geographic, right? The donor countries, North, Global South has its power, inherent power. And I have experienced that when we go as a team from North to the South countries, even if we try to level the playing field, have the table laid out that's equitable, if we don't make explicit effort, and often the power dynamics is inherent. So people do see, oh, this entity or this person or this advocate is coming from US, and when you sit at the table, your voice gets more weight than the others. So it's upon us in that moment to actually do the effort. Donors have more, gender, race, all these are inherent power holders, right? So let's go to the slide. If you see there in the slide, what we need to do for the shifting the drivers of the powers that putting people over profit, right? So we talk in terms of money, and then using the human rights language. We talked about it when we started talking about health equity, and all of the group had predominantly agreed that it's a human right, right? It's a human right framework that should drive, not the profit, not the philanthropic, not the charity. So that is a very important shift that we need to, when we talk in terms of it's health is a right, and health equity is part of that basic fundamental human rights, whether it's enshrined in our country constitutions or global framework or in SDGs, Sustainable Development Goals. So putting that, when we talk about, when we go and advocate, we make ourselves conscious that we need to use that framework rather than me helping you or my country helping your country, is that it's a shared human rights value, and people are more, come before the profits. Now, equitable partnership. So equitable partnership, I think we are right on time, so I'm going to rush through it. I wish I didn't have to, but let me just quickly wrap up. Equitable partnership, what does it mean? You see all these partnerships in Global South and Global North. When we see in Global North, the entities embodied in Global North, whether it's multilaterals, whether it's a small NGO CSO partnership, the power usually stays in North. That paradigm needs to shift. That driver of power needs to shift. Localize and decentralization, decision making. So here's the thing with that decision making. It should not only appear that decision making is shared, but it should actually be shared, right? So that's a very difficult thing to happen. So localization and decentralization of decision making has to happen. What does that mean? People are involved at the conceptual level all the way through to the end, whether it's a project, whether it's an effort, whether it's a partnership, whatever that is, it should start at the concept. We can't bake the concept here in the US and then take it to the Global South and then say, oh, we are localizing. That is not going to be the effective way, and it's not decentralization. Global South perspective and leadership. We saw in our discussion that most of the voices we heard come from Global North. That needs to shift. Transparency and accountability. All of us at small level, at large level, at the government level, at the multilateral level, transparency and accountability. It is my firm belief and experience over 30 years working on it. When transparency is not there, there's a reason behind it. There's a holder of the power holding that. So transparency, privacy, and keeping it tight is two different things. Right? So transparency can happen at the most levels. Let's say we go to the doctor, keeping our private information is privacy. Keeping how the doctor function is transparency. Do they provide the information to the patient? What we did with you, what are we going to do with you? And what is your right? That's transparency. And accountability. Transparency leads to the accountability. One, accountability comes with it when we are transparent. And second is that it gives that opportunity to all stakeholders to say, hey, this is what we agreed upon, but I see this. How did that happen? Ability to hold people accountable in power at all levels. So I hope you enjoyed this session, and I hope we all are getting something. I know I learned a lot. So let's keep the conversation going. And then we are going to unmute for a minute so that we can say bye-bye to each other in our voices. And I am so thankful for your time and for your thought sharing. Thank you. And please stay engaged. Can we unmute everybody and say bye?
Bye.
Bye.
Thank
you.
Everybody. Bye.
Have a wonderful day.
Bye.
Bye.
All right.
Y'all come back now.
I'll come back now.
Thank you.
I'm
Thank
so
you.
glad
Thank
we
you.
had this time together. Goodbye, everybody.
Bye.
Awesome. Thank you.
Bye bye.